Good afternoon, everybody. It's a pleasure for me to introduce the speaker. My name is Anand Karnad. I'm the Chief of Hematology and Oncology here. And Martine has been, to me, personally an inspiring figure in geriatric oncology and has taught me a lot about the care of the person who is over the age of 70 with cancer and how to deal with this. She is one of the leading figures in the field of geriatric oncology and is currently heading the program in senior adult oncology at the Moffatt Cancer Center in South Florida, which is one of the most important institutions for research in aging and cancer, and therefore has had a natural relationship with this institution, which also has powerhouses in the basic and translational sciences related to aging and cancer. Martine has done a lot of very important work on both sides of the aisle, that is to say, at the bedside in helping us understand and improve the care of the patient with cancer, pushing the boundaries of taking care of people who are not just tennis player 70-year-olds, but 80, 85, 90-year-old persons, and how do we make sense of taking care of the patient. Important contributions to understanding the impact of frailty, comorbidity in relationship to cancer and aging. So with that background, I'll have Martine take the stage.
Okay, thank you very much. So I think if I do that, I should have you okay. All right. And then, okay. Let's get things going here. All right. Okay, so it's a pleasure to see several of you again, and I really always love to read articles of research on aging that you guys do. It's always interesting to do. And what I decided to tackle today is tease you a little bit. So there are things we can study on aging and cancer in mice. There are things we can study in clinical trials. And then there is this very popular thing right now called big data. And I want to explore with you a little bit whether that could help us understand aging and cancer and what can be done with these big data. So this is the reality of American epidemiology today. If you are a woman, 1 chance in 3 you will have a cancer somewhere in your life, and if you're a man, it's 1 in 2. Welcome to the future. Chances are you may have cancer. And when we look here, the median age at which cancer is diagnosed in the US today is 67, or at least in 2005, and it's creeping up towards the 70s. And if you look, the most frequent cancers like prostate, the median age is 68, bladder is 73, stomach 71, pancreas 72, CLL 72, lung 71, colorectal 71. So all these cancers really happen to people in their 70s and 80s, half of the time, and more than that. So cancer and aging go together. I'm going to divide my talk in 3 parts, laboratory, clinical, and big data. So this probably, under one form or another, is very familiar to the aging and cancer researchers in this room. But as we age, there is a complex relationship between the risk of cancer and aging. And some mechanisms do help prevent cancer, and some mechanisms do so at the cost of aging more and others do that at the cost of aging less. So to suppress a cancer, we essentially have two sets of mechanisms. You have the caretaker mechanisms, which prevent damage to the DNA, repair DNA damage. BRCA would be an excellent example here. And these will increase the longevity of the patient. But then you have the gatekeeper genes, which, if the cell is damaged and mutated, would kill your cell. Okay, and two things can happen. They can become apoptotic and completely disappear, or become senescent with its own set of problems down the line. And if you have these cells that are senescent, or you apoptose enough cells in an organ, then the cost of preventing cancer is going to come at the cost of aging your organ. So when I said that senescent cells have a cost down the line, there is an increasing amount of evidence, and these are just two examples, that senescent cells promote tumor growth. You have secretory phenotypes like IL-6, for example, that in multiple models do promote tumor growth. And this is being explored under various forms in both animal and human data. What we also know in several studies is that as we age, the tumor profile can be different. This is a series that Chris Benz in California has of breast cancer that have never been treated. So he has a natural history of this breast cancer, and he has tissue. And you can see in yellow the quote, aging profile is really in older women, with some exceptions here. And he reproduced that in two of our group of patients. And you can separate two different gene profiles in your older people, transcriptome profiles in your older women with breast cancer. I'll show another example in a few slides. And there are a lot of research doing that. It's not always easy to do. And we've tried to do that in ovarian cancer at Moffatt and looking at gene expression panels. And we were not able to find a reliable association with aging between the Moffatt data, the TCGA data, and the Toadhill database. Sometimes it was matching in 2 out of 3, but not all 3 of them. So this is work in progress, but there are definitely things that you can find in human tissues and in animal models about changing the biology of cancer and age. Now, we are in San Antonio, and you know all about rapamycin. So rapamycin does expand the lifetime of all these animals, delays the onset of morbidity, reduces the decline in spontaneous activity. And as you and your collaborators have very well demonstrated, you can start it in young mice, old mice, and you can prolong the lifespan of these mice. Now, what is becoming interesting, okay, this is the activity slides, and again, you can see that rapamycin helps things. Now, where things become very interesting is that derivatives of rapamycin are used in cancer trials. Everolimus is one of them. Temsirolimus is another one of them. And what you can see here is that they increase progression-free survival. That's the first cohort here. So time to progression is definitely higher. But what is extremely interesting here and teasing is that the survival curves separate even more than the time to progression curves. Okay, here, the time to progression, they kind of separate and then kind of stay together. Here, the survival curve keeps separating. So is there, beyond the anti-cancer effect, an anti-aging effect of everolimus? We don't know that. But that's tantalizing.
Excuse me. What cancer was this?
Breast cancer, sorry. Yeah, breast cancer. So everolimus is now an accepted treatment for metastatic breast cancer, first line and second line, and in conjunction with hormonal therapy. It's pretty, I would say at 5 milligram it's well tolerated. At 10 milligram, a lot of patients have nausea side effects. And every once in a while I have a patient who loses appetite completely, loses weight. So everolimus is a bit all or nothing. Either it's very well tolerated or the patients have so many side effects I have to stop after 2 or 3 months. Yep.
So when we talk about survival, I mean, obviously breast cancer in younger women versus older women is kind of a different disease from a progressive perspective. Is this all comers, or is this more women, or is it younger?
No, that was all adult. This was pre and postmenopausal, and the Bolero trial was with exemestane and was only postmenopausal women.
It'd be really impressive if it was premenopausal. Yeah,
right.
It's still impressive.
Right. So I think tantalizing data. We tried to piggyback an aging and cancer study, aging study on an adjuvant trial of everolimus that is still ongoing, S1207. Unfortunately, like often happens with cooperative trial, you start with a great idea, but the great idea has to go through 10 different committees before it actually gets to be accepted. And by the time we were getting close to opening it, the study was not accruing quite as fast, the main study, as it should, and they had to reduce the size below the size that would have allowed us the power to do the ancillary study. So you will see soon the results of a trial of adjuvant everolimus in breast cancer, but without biology of aging. But it will be interesting to see what the survival curves do in this adjuvant study, because, of course, you have the opportunity for more follow-up in an adjuvant trial than in a metastatic disease trial. So, with all that, consistent with this yin and yang association of cancer and aging, people have tried for many years to do find geroprotectors, okay, in animal models. And here is a whole lot of geroprotectors that have been reviewed by Anisimov. And you can find they all, of course, increase your mean lifespan. But the effect on a tumor is different by category. So the first category simply delays tumors, same incidence. So you have this like procaine, for example, 2-mecaptoethylamine. You have another group that is going to increase the latency of the tumor and decrease the incidence. Okay? So this is the one you really want. And you probably know it already, the diet. If you starve these mice, you decrease everything. It's hard to translate in human because the studies were done with a 40% reduction in calories. And it's hard to get a human to eat 40% less calories than they do. And then you have some drugs that prolong the lifespan, but also do increase the incidence of cancer, at least in mice. And what is kind of interesting, and it really is a call for trials of aging and cancer to talk to each other, is that selenium and vitamin E were actually a very, very large prevention trial, the SELECT trial, several thousand of patients, millions of investment. And it was a negative trial to prevent prostate cancer and other cancers. And when you look at the animal data, you would have said, well, maybe that was not the best choice because of that. And a better choice might have been to use biguanide. I mean, we know all about biguanines in humans. I mean, we give that for diabetes since ages. Okay, that's metformin. Metformin is one of them. And so these are safe drugs, and there are studies actually going on with that too. So the problem with animal studies is you have a gap when it comes to cancer treatment. The classic way of developing cancer treatment is to use a mouse model, and then if it works, then you try to go to human studies with a few intermediate steps in another animal species and safety things. In your phase 1 studies, what happens is that 9 times out of 10 it doesn't work. And it's called the death valley by the pharmaceutical industry, because you have so many drugs that die between the animal model and the phase 1 study. This said, I would like to suggest a hypothesis here. One of the reasons where things might not work is that your typical mouse experiments wait until your mouse is 6 to 8 weeks old and then start injecting tumor cells and doing all sorts of things. However, that 6 to 8 weeks old mouse is a teenager. Okay? She basically just became able to reproduce. And what we have seen is that cancer happens in patients 67 years on average. So there's like a 50-year lifespan in humans of senescence that happens. And so what may work in young mice or young individuals may not necessarily be reproducible in older individuals. And that may be one of the reasons that you have the failure of so many drugs. So what I would like to suggest is, okay, you screen in young mice because it's quick, because it's cheap. But then, once you find something that is positive, you should test that in some old animals. I put an old mouse, but some people told me that old rabbits probably would be a better idea. It's a closer model, apparently, to old humans. And so these compounds would go through an intermediate step, and if they still work in old animals, then we would have a better chance of having them working in an old human. So what I hear from the lab people is, oh, well, all animals are expensive. Okay, sure, they cost $50 instead of $5. Okay. Well, do you know how much that costs to put a patient on a phase 1 trial? Nowadays, it's about $20,000 to $25,000. That's a lot of old mice. Okay. So, I think that's worth exploring. It could very well be done retrospectively. You take 10 drugs that did prove successful in clinic and 10 drugs that did not, and you retrospectively test them in old animals to see whether you could have predicted that and avoided the cost of going to a phase 1 trial. I love for somebody to do that experiment, so.
It sounds good, but there are only data support this idea. Battery.
Right. So there are some data about, at least in some cancers, you can see definitely a worsening prognosis with age. There is, you can have in lymphomas, hematologic malignancies might be a good model to start with. A, because they are simpler, and B, because we know more about their age dependence, like the prognosis of lymphomas worsens with age, the prognosis of AML worsens with age. So that's there's been opposite models as well. Old animal models showing melanoma not growing as fast in older people. Probably because of less immune reaction around them.
With the human data, I'm very far afield from this, but you think of childhood leukemias. Are adult leukemias, are there some overlapping in the types of leukemias and then knowledge about the efficacy, which is quite good, as I understand, in childhood leukemia versus
Right, so the types of leukemia are, you have acute lymphoblastic, acute myelogenous. The frequency changes with age. The ratio of lymphoblastic to myelogenous in children is 9:1. In older adult, it's inverted. It's AML9, ALL1. The biology in children is often a fairly developed progenitor. And the more we age, the more the progenitor moves toward a stem cell. And part of the resistance is that the older AML patients often have stem cell-like expressions and are more resistant to treatment, and you have less regenerative capacity of your bone marrow.
But in a sense, then that sort of supports your hypothesis, doesn't it?
Right. So I think there are various strands of evidence. I cannot tell you I have a very strong mathematical model of interaction of aging and cancer, but I've been wondering, because I believe senescence, with all the senescence-associated phenotype, probably promotes tumor growth. And what we don't know well in oncology is what happens to the last cancer cell. Okay, we know that with chemotherapy, we kill 99.9% of cancer cells. But when we achieve a complete remission, what happens to this last cancer cell? Is it the body recovering immunity to finish wiping out the thing? Is it that there was latent damage that ultimately led to apoptosis? Is it that there is competitive growth of tissues? We just don't know. Yeah?
So, in this model, there's obvious advantages, cost advantages, and time advantages before you go to the human to phase 1 trials.
Right.
But we have huge monkey colonies here. We can look at primates that have similar diseases. They have an HIV-related infection, SIV, and it produces malignancies and things like that. And we have a lot of animals here that we haven't experimented on in any particular way that would necessarily, at least we think, would necessarily induce cancer in age. And these animals may be 25 or 30 years old.
Wow.
So we could, in rhesus or July baboons or whatever, or even vertebrate monkeys, we could induce this kind of experiments.
Yeah, that would be probably even closer to humans.
Than going to phase 1 with humans, where you have a primate model.
Yeah.
Finland was telling me they cost more. It costs about $7,000 a year just to maintain these animals.
Yeah, well, monkeys are more expensive than mice, I'm sure, but yeah.
More expensive than human.
Yeah, how is it? Yeah. Okay. So, again, when we speak of, in the oncology world, when we speak of targeted therapies, we often think of the tumor. We analyze nowadays the tumor genetics with exquisite care. We do Foundation 1 panels or Quadrant 360 panels. There's like 600 genes panel telling you whatever variant of known or unknown significance is present in your tumor. But I think it's only one side of the story. The tumor grows in a microenvironment. That microenvironment is affected by all sorts of cytokines, inflammation, host-tumor interaction, and age. Okay, senescence is where it acts in the microenvironment. And then, when we really want to do precision medicine, there is also a macro environment that has been little explored. Animal models are clones and usually pretty healthy. But if you think about it, a patient comes and they have diabetes and they have cardiovascular problems and they take aspirin and they take metformin. And how is all that influencing what your cancer does? So these are kind of questions that animals models are not so good at analyzing. So we learn a lot from animal models, and as I said, I'm a fan of what you guys do. But there are questions we need to move to humans to try to answer. So let's do it. Age is correlated with frailty. But the point I want to make with this particular slide is that being old, even in your 80s, does not equal being frail. The prevalence of frailty does definitely increase, but you can see that even in patients in their late 80s, if you look at the free definition of frailty, you still have a good half of these that are not frail per Fried criteria. So we'll have to distinguish between patients who are frail and who are not.
I'm curious, I was wondering if you can comment on the blip that you get between 85 and...
That's low number. That's just low numbers.
Okay.
Yeah. Yeah. That's the end of a curve thing. The other thing that happens as we age is we tend to develop more comorbidities. And the cancer patients I see have on average 3 different comorbidities beside their cancer. And when people hear the big C word, they think, oh, this is threatening my life. However, less known is that a lot of our diseases are actually threatening your life expectancy. It's just not in the mind of physicians and patients as much as it is for cancer. And here's a little comparison table. If you want to live 5 years, it's better to have breast cancer than diabetes, actually. You have a 70% 5-year survival with diabetes, and you have about 75% with breast cancer. It's better to have stage 1 non-small cell lung cancer than a stroke or moderate severe dementia. It's better even to have stage 3 colon cancer than being hospitalized for COPD. Okay. Now, metastatic cancer is still not a very good news if you want to live 5 years. Okay, so once it's metastatic, it tends to become the major problem. But early stage cancer nowadays is very much a comorbidity among others when you look at the life expectancy of your patient. It gets even more complicated. Let's suppose you have colon cancer and you have diabetes. You get the same regimen. This is a large randomized trial. And you can see that the diabetic patients are not doing as well at 5 years than the other patients. Okay, there is that 20% difference. Now, where it becomes really interesting is this is not an overall survival difference. It is a relapse-free survival difference. So, colon cancer patients who have diabetes relapse more frequently from their colon cancer in a randomized trial where they all got the same treatment. There was no difference in treatment completion, okay, it was all the same. And the diabetic patients relapsed 20% of the time. How big of an effect is that? Same effect as giving adjuvant 5-FU levamisole, versus not. Okay, so it can completely negate, statistically at least, the effect of your adjuvant chemotherapy. Big confounder for a clinical trial. And we know very little on the impact that comorbidity has on cancer in general, on the behavior of cancer in general. And this is where the macro environment that I was mentioning starts to become very important in humans. It gets even worse. you have diabetes, fine. But there are a gazillion drugs to treat diabetes. And this is a breast cancer study of neoadjuvant chemotherapy. And here is the non-diabetic patients. And with that neoadjuvant treatment, you had a 16% pathologic complete response rate. And you look at the diabetic patients, and you can see that if they had no metformin, they only had an 8% complete response rate. But if they were taking metformin, 24% complete response rate. So it's even higher than the normal patients. So not only does diabetes influence the effect of your treatment on cancer, but the drugs you take for your comorbidities do influence the treatment of your cancer patients. How many drugs does an average older American take? 6. 8. Yeah, well, maybe it's 8. Yeah. In the mid-90s, it was 4. In the mid-2000s, it was 6. Maybe now it's 8. Okay? And of these, at least 2 interacts with P450. So, a lot of things that we really don't know about what influences the behavior of a cancer. So can we use a CGA to help us sort out the patients, okay? And this is an Italian study, and I just love that study. I'll tell you why. Dr. Tucci went to see her colleagues, oncologists, treating lymphoma, diffuse large B-cell lymphoma. And she told her colleagues, I'd like to do a study of geriatric assessment to see if we can direct treatment. And her colleagues say, oh, ma, we know how to treat older cancer patients, no problem. We can tell who is frail, who is not frail. Dr. Tucci said, okay, fine, you do your thing, okay? And we record who you estimate is frail, who is not, who you give curative intent treatment, who you don't. And I'm doing my CGA in my corner, and we'll analyze all that.
I'm sorry. What is CGA?
Oh, sorry, comprehensive geriatric assessment. So comprehensive geriatric assessment, you would look at their physical function, you would look at their, if they have geriatric syndromes, you would look at if they have fallen, nutrition, depression, cognitive status, kind of evaluate the patient and screen for problems. And she used a definition of frailty in her study, Balducci, for those who knows that. And here is the result. Half of the patients were deemed frail by geriatric assessment. 3/4 of the patients were treated by curative intent by their oncologist. So if the patient was not deemed frail by geriatric assessment and their oncologist were not deeming it frail, well, everything happened as it should. Okay, 80% survival, that's what you get when you treat a diffuse large B-cell lymphoma. So when everybody agrees, no problem, fine. Now, the second group is these two curves where people who were deemed frail by the geriatric assessment, half of them had curative intent treatment, that's the lower curve, and half of them were deemed frail by an oncologist and had a palliative intent treatment.
And what?
A palliative intent treatment. And no difference. So the CGA was better at predicting outcome than the oncologists were in that study. This data has been reproduced. There are at least 2 or 3 different, half a dozen actually, different studies showing similar results, not as elegant in design as Tucci's, but doing a comprehensive geriatric assessment definitely adds to our ability to predict what is going to happen to our patients. So not only comorbidity, but indicators of frailty that may be hidden clinically are going to tell us how to treat these patients and how they are going to do with our treatment. So that's what we get from human studies, that there is more variability that we can recognize and use to help us guide our treatment. Based on that, patients started, clinicians started to do clinical trials and say, okay, let's do a geriatric assessment, intervention, before choosing treatment, and see whether that changes what the treatment plan is. So these are, this is a meta-analysis of that, for if you want to see it all at once. And you have here 6 studies that look at how many times the geriatric assessment did change the initial treatment plan that the oncologist had in their mind. And it's anywhere between 20% and 49%. So if you take the time to assess your patients beyond your basic oncologic assessment, you do change your treatment. Now, sometimes, most of the time, it was a less intensive treatment, but you also had more intensive treatment in some studies and some cases of treatment delay to have a geriatric intervention to boost up your patients before you were treating the patient. Yes? No, this is like, that's all sorts of, usually these studies were addressing all types of cancers. They had different scheme. The Kenny's study was very simple. A little screening placed in the chart of the oncologist for them to look at. And that's changed 25% of the time. Other studies, like, for example, CHIBES, you had a geriatrician consult and give a report and discuss with the oncologist. So the intervention has some diversity here, but seems to influence treatment. Here is not only the cancer treatment was impacted, but there is a lot of non-cancer treatment that also gets modified. That may also help. If you control better your blood pressure, if you control better your diabetes, you likely will increase your tolerance to cancer treatment. Here, the type of intervention that was done was quite directly correlated. So if you just had a screening, it was only 26%. If you had an interdisciplinary team with like a pharmacist and a dietitian and everybody, almost everybody got some intervention. Okay. Okay, so we changed the treatment decision. Are we changing outcome? Okay, the proof is in the pudding. You can change the decision. If it doesn't change outcome, well, you know, it's a fancy thing. But if it changes survival, for example, that becomes something much more important. This is a study by Ruth McCorkle and her team at Yale. They did a 1-month post-op intervention. They had patients undergoing surgery for cancers of various types. It's about 500 patients. And they were randomized to have that 1-month home intervention after discharge. That was 3 home visits, 5 phone calls by a nurse practitioner. So twice a week a contact. And what you see here, the overall survival was better in the intervention group, and it was mostly driven by the advanced cancers. And the difference was totally striking. For a 1-month intervention, you had a 27% absolute difference in 2-year survival. Why? Ruth McCorkle did not make hypotheses. As an oncologist, I have a couple. Number one, they may have prevented death. They had 8 deaths in the control arm, 1 death in the intervention arm during that first month. And it was not statistically significant, but they might have detected early complications from surgery and helped prevent deconditioning and other complications. The second thing is if the patient was in better functional condition, probably that patient was more likely to have a standard adjuvant therapy or subsequent chemotherapy than if they had been deconditioned. And that definitely would correlate very plausibly with a survival difference. That study, unfortunately, was published in the Journal of the American Geriatric Society, which almost no oncologist reads. So it has been a struggle to get that accepted in the oncology world. And that's something that needs to be pursued and reproduced until the message comes across. Here is another geriatric intervention study, this time in a more general population of patients. And they did 70 observations and 65 with a geriatric intervention. These are chemo patients. They had a screening. If they were positive, they were referred for a geriatrician intervention. And of the 65 in the intervention group, 46 did actually see the geriatrician. They had 300 interventions with almost all patients requiring at least one intervention. So same thing that we saw in our pilot study in breast cancer patients. Almost everybody has something that can be fixed. Now, here is where it becomes really interesting for the oncologist. As in the intervention arm, 1/3 of the patient could have their treatment as planned, versus only 11% in the control arm. So really what the geriatric assessment allowed was to better tailor the treatment to the patient and being able to deliver that treatment fully. They also had a trend towards less toxicity and slightly less death in a 6-month time point, but it was not significant statistically, small sample. If you are visual, that's what it looks like. Treatment as planned here, and the number of deaths at 6 months. So these are still early trials, I would say. There are more going on. But there is an increasing amount of evidence that having a combined geriatric and oncologic approach in clinical trials seems to improve things. And does it make a difference in real life? This is a study we published on metastatic breast cancer patients. Those of you who treat breast cancer know how hard it is to demonstrate a survival advantage in a clinical trial of metastatic breast cancer patient. What you see here, we compared the Moffatt patients to the Dutch Cancer Registry. Now, why the Dutch Cancer Registry and not SEER Registry? The Dutch Cancer Registry has much more details on medications and treatments than the SEER Registry. And so what we see is that you have less mortality over 3 years in the Moffatt patients than in the Dutch patient. It was like borderline significant. The reason is we had to focus only on primary metastatic patients because a cancer registry only registers the stage at diagnosis. It does not register well the relapses. So these are small numbers, but again, tend to confirm that an oncogeriatric management seems to improve prognosis. I'll make a little caveat here. As we are getting more successful at treating patients, some nasty minds have asked themselves, well, you know, with cancer therapy, we generate senescence in cancer cells and apoptosis in cancer cells, and we kill them. What does it do to the patient? Do we age our patient when we give treatment? Good question. We have some laboratory data. This is already a fairly old paper looking at DNA cross-linking in the monocytes, of donors who were either less than 25 years old or more than 72 years old patient. And they used cisplatin, which is an alkylating agent, and looked at how long the DNA cross-linked persisted in the monocytes of these patients. And you can see that the younger patients have less cross-linking and it resolves faster than in the monocytes of older patients. So the damage from cisplatin tends to be more persistent. This is another study where they did look at whether chemo was shortening the telomeres of the mononucleated cells of these patients. And you can see that below the age of 55, there is some reduction. But if you took the group of above 55, then that reduction was much more pronounced. The shortening of telomeres was much more pronounced. So here, again, chemotherapy might, quote, age the patient. Now, many things can influence telomeres. Even exercising lengthens your telomeres. So that's a bit difficult nowadays to really follow a patient and say, okay, this is how I shorten their telomeres. But there is a more recent set of data from UNC that I find fascinating. And they looked at P16 INK4A. They had a set of samples from pre- and post-chemo patients. What you can, you have control groups, which is, these were breast cancer patients. The red ones had chemo, the blue ones did not have chemo. And they looked at their cohort, and they found that the expression of P16 INK4A was higher in the patients who had had chemo. And this was actually corresponding to about 10 years in aging from the chemotherapy. So, yes, we prevent death from cancer, but as our patients live longer and longer, we may start asking ourselves these questions of cost-benefit 10 years down the line.
What cell type was that?
That was monocytes, peripheral blood monocytes. Lymphocytes. Yes?
What kind of chemotherapy?
Oh, that was the classic adjuvant breast cancer regimen. I don't think they were specifying one regimen. So it would be probably anthracycline and taxane containing regimens, I would bet. So, worth talking with Sanoff and the others from the UNC group. The advantage of P16 INK4A over telomeres is that with age between 20 and 80 years old, the expression increases 10 times, whereas the telomere shortening, you have much less bandwidth as far as age is concerned. Okay, so since we are in human trials and we are speaking of cancer patients, it's hard not to speak about phase 3 trial because in the oncology world, that's the reference. Every time you can have phase 3 data, it's level 1 evidence, and nobody can contest that, and you stand on level 1 evidence and bump your colleagues with that. It's really the ultimate evidence. So how does that address our older patients, and how useful is it for our older patients? So here you have a patient who is trying to cheat randomization. The problem of phase 3 trial is that in the population, half of breast cancers are above the age of 65 and a quarter of them are above the age of 75. Yet in clinical trial, only barely 20% are above the age of 65 and only 4% are above the age of 75. So the patients who come into your phase 3 trial become a very selected subgroup of population. And that's 1994. So you are going to tell me, oh, wait, these are old data. Well, if you look at the Alliance trial, you can see that 23 years later, okay, oops, that thing I think died. 3 years later, we have 17% of patients above 65 and 9% above 70. So zero progress in 23 years in the number of patients above 75. Here is another way of looking at it. This was all NCI cooperative group phase 2 and 3 trials. And you look at the proportion above the age of 65, which is yellow, and above the age of 75, which is blue. And between 2001 and 2011, there is strictly no change, despite 2 decades of advocacy. Okay? Why is that? Comorbidity, eligibility criteria, physicians being reluctant to put older patients in clinical trials, and it's very difficult to change. The patients, interestingly enough, once we offer them a trial, half of them are going to say yes or no, no matter what their age. The older patients are just as likely to say yes than the younger patients once the oncologist proposes the trial. So, the clinical trials, as I said, are really the rock bed of evidence on which we base our oncology guidelines. And these guidelines are widely used by oncologists worldwide. And we refer to them when we choose treatments for our patients. These trials are based, these guidelines are based on these clinical trials that are underrepresenting older patients. So what we did ask in a review was, okay, let's look at all these studies that are in the NCCN guideline and the ESMO guidelines. And let's look at a cohort of lung cancer patients age 80 and older at Moffatt and see how many of these patients would have actually matched the eligibility criteria of these trials. Okay? The ones who match, a priori, you would say, well, then the evidence applies. But if they did not match, you would say, well, we don't know if these phase 3 trial results apply to these patients. And we borrowed an idea from the Dutch people of saying, well, if more than 60% of the patients match the clinical trial criteria, then the evidence should be followed. Okay, 60% is what we think, in general, the guidelines apply to cancer patients. Okay, we admit that there is always a subgroup of patients that, for a reason or another, will not directly have guidelines applicable to them. The evidence partial if they have 30 to 60% of patients who match, and then a limited evidence if less than a third of patients do match the inclusion criteria. All right, let's look at the questions. If you want to choose between a lobectomy versus a more limited resection, these are ESMO guidelines and CCN, in the middle, partially applicable. Concomitant chemoradiation versus sequential chemoradiation, good evidence, you can apply. Adjuvant chemotherapy versus not, good evidence. Neoadjuvant, we don't know. Giving double agent versus single agent. The NCCN guideline were citing more studies. It seems like more robust. Do you give a platinum regimen versus not? also fairly robust. What is the best treatment, best first-line treatment for patients with performance status of 2? Well, we don't know really for older patients. Targeted therapies, maintenance, yeah, good evidence for maintenance therapy, not much for the rest. Okay, so if you treat an 80-year-old, and sometimes the guideline can be applied reliably, in other cases, you're kind of left on your own. All right, so we've looked at animal data. Great for understanding the mechanisms of things, but not so great for comorbidity and frailty. We've looked at human data. Cohort studies are pretty good for analyzing comorbidities and frailty. But if you look at clinical trials proper, they don't always apply. So what should I do with that 93-year-old bladder cancer patient who has an ejection fraction at 45% with his heart and has some limitations in their activities of daily living? What's the best treatment? Will I be able to make a clinical trial that is enrolling 93-year-old patients with these problems? No, never. Does it mean I'm stuck? I don't think so. And that's, I think, where big data can help us. When we speak of big data, it's one of these buzzwords that, like, everybody has some idea of what it is, but what is a proper definition of big data? And this is how I would frame it. A very large, diverse, and rapidly evolving set of data collected in a structured fashion and retrieved via analytic software. Functionally, big data is that whose scale, diversity, and complexity require a new architecture, techniques, algorithm, and analytics to manage it and extract from it. Okay, so something very dynamic as an amount of data that constantly changes and evolves. Now, lab researchers have been using that for quite a while. The Cancer Genome Atlas, SwissProt, there's a lot of laboratory database, molecule database available online that lab people dig in all the time. Okay, you have the entire genome of Caenorhabditis elegans and Drosophila and some mice, and you can simply compare your sequence to that. The searches in research are often anonymous, and you don't have directly correlated clinical data. If you want to have more precise data, like you look at these large cohort series, you often have to go through a query authorization that can be a fairly lengthy process. If you want to access the SEER Medicare registry, for example, it's a few months before you get the authorization. So it takes time, and then you have to have the staff to extract and analyze those data. That is fairly limiting in clinic. In clinic, the oncologists are extremely busy, even more now that they have to type into an electronic medical records. You know that an oncologist spends about twice the time in the computer than they spend seeing the patient nowadays. So the question is, can we somehow deliver the substantific juice, the concentrate of big data to the oncologist right at their fingertip? Okay. Or can we make that available as a consultation? That somebody will do the job for them and give them some results back. And that's at the same time the promise that you hear from ASCO, that you hear from Moffatt, that you hear from Watson, that you hear from all these big data systems, Google Health. That's the promise. They say, oh yes, we'll be able to use that to improve your care. How realistic is that? Are we going to be able to do that? Well, this is the Moffatt one, Total Cancer Care. It started 12 years ago. It's a bit the ancestor of them all. And it was very much driven by translational research. They wanted to have samples, link them to clinical data, be able to direct patients to protocol to match them with their mutations. In the process, they developed a complete infrastructure of data extraction, of clinical data extraction. And so that database now has the 120,000 patients who provided a sample. And they also have the 500,000 Moffatt patients who were entered simply because we downloaded from the electronic medical record and the system was there. So a very rich data environment. We learned a lot of things. One is that when you assemble data from cancer registries and clinical data and pathology reports, everybody codes things differently. And so you have to develop a meta-language, put that in a big data warehouse, and finally you can extract that with an extraction software. We were naive, honestly, when we started that. We thought we could do it ourselves. Well, after 3 years, we realized we have to involve the biggies, and Oracle has been working with us to co-develop that. Okay. The result is pretty neat. I can be at my desktop, open my portal, and it looks a bit Facebookish like that, and I can look like at my frequently used variable and say, okay, how many patients did we see with lung cancer, stage 3? And how many of them were EGFR positive? And how many of them were 70 and older? And how many of them? So I can very quickly get a sense of the number of patients available. This is anonymous. So I cannot, from that portal, I cannot know the name, the dates of treatment, all the confidential HIPAA information does not appear here. It gives me an approximate date, and it gives me the true diagnosis and the true labs. But the dates are changed. After that, if I want to have more data, I have to ask data concierge. And then I can get the real data with an IRB protocol and everything. So what can we extract from that kind of data? Here is a paper on senescence-associated gene signatures in glioblastoma. And what we found is the higher the grade of the glioblastoma, the higher the expression of senescence-associated genes. So that was interesting. They looked at other tumors as well, but this was the striking result in the series. And I think that's a nice discovery tool, because we have the tumor grade and the patient parameters in association. This is the age of the patient. And again, the higher the age of the patient, of course, the more senescence-associated genes you have in the glioblastoma. Now, is the expression in the whole patients and subsequently in the tumor, or is it more pronounced in the tumor? That the data does not say it. But that gives us a handle about how to go about testing that in more formal animal models or human studies. So a great discovery tool for that kind of expressions. This is another way of using this data. I mentioned that comorbidity thing. I told you, well, a patients have 3 diseases at least on average, they can influence treatment. When you do just study one disease, you have to limit yourself to frequent diseases because you need enough patients for the power. So diabetes has been studied, cardiovascular diseases have been studied, but what about the others? And do they act alone, or is it a cluster of disease that is going to influence your prognosis? And are the same disease influencing function, or survival, or toxicity? Probably not. So what I'm trying to do right now is use all the heat map approach, and instead of gene expression, put comorbidity expression. And I based that on the CRSG, and you can see that the patient at high risk of death, this is death, the risk of mortality risk, there is a subgroup that we identified that is at high risk of death, and you can see a striking difference in expression of severity of comorbidity for hematopoietic diseases, liver, heart, respiratory, and upper GI, and musculoskeletal integument. So that left side is the highest odds ratio. You can have some very frequent diseases here, like vascular hypertension. A lot of our patients have hypertension, but there is no really significant difference in distribution, contrary to cardiac diseases. What we did from that is we took that high-risk score that was getting 1 point for either grade 3 hematopoietic disease, heart disease, respiratory disease, musculoskeletal disease, or a grade 2 or more upper GI and liver disease. And you can see a pretty good difference in survival. So that's one of the use of big data, is to try to take all these patients in less than ideal condition and try to understand whether we can extract guides for our treatment. Another usage of big data is the molecular tumor board. That's something we have at Moffatt. We call it the Clinical Genomics Action Committee, because they want to come to an actable decision when they do these things. And they review all these Foundation 1 and Guardant 360 that we order all the time nowadays for our cancer patients. And they search for similar mutation in TCC or TCGA of our databases. After that, they provide a consultation report to the oncologist with suggested treatment, clinical trials, or the frequency of these mutations in various tumor types. The Foundation report has some automated reports, but this goes far beyond that. I've seen both. I can tell you this is much more developed. A second way that we could use big data is to integrate clinical pathways into the electronic medical record. You take these NCCN guidelines I was mentioning, and you could have an automatic call, is that when you click for treatment decision, you would have a pop-up that says, okay, stage 3 lung cancer with this and these characteristics, per NCCN guidelines, treatment of choice is this or that. CancerLink is working very hard on that. That's what they want to push ahead in clinical practices of oncologists. Moffatt also has a little more detailed pathways than NCCN guidelines, and we are going to try to improve the quality of our practice with that. It's a relatively low-hanging fruit because once you've placed the algorithm inside the EMR, all you need is update the text of it, and it will pop up. The third thing we tried is remote consulting. The majority of older cancer patients is treated in local medical oncologist's office. Now, a local medical oncologist will never have the time in private practice to do a PubMed search about the patient and things like that. Furthermore, we saw a lot of these patients would not qualify for clinical trials. So what we did try to do is that we worked with an outside institution, and they were doing a little screening, a geriatric screening, and doing their oncology workup, and then the question was, is there a treatment decision to make? Do they have geriatric problems? If that was the case, they were sending us an email with a pre-formatted email with the profile of the patient, intended treatment plan, and a few more details. We would search that TCC database for similar patients with a little portal, with sending it to our extractors, getting the Excel data sheet with the patients, checking in their chart if the patients were truly matching, and extracting a case series, commenting it, and sending it back to the local oncologist. So if you could do that in real time, this is really something that could add to the evidence loop and be of use for a lot of people. So we did the pilot with Lynn Cancer Institute in Boca Raton, which is a private cancer center. And the scheme here, you have all the steps, but what we wanted to have is something that can be done within 3 working days. That was our feasibility target. If we can do it within 3 working days, it's a potentially helpful clinical tool. Oui?
So the intervention was not necessarily a geriatric assessment, but more review of the database for similar cases and what their outcomes were.
Correct. The reason we asked them to do a short geriatric screening was that we wanted that to be also a possible entry if they wanted to have data. We have in our electronic medical records geriatric screening data. So we could match a bit better the patients for geriatric problems, IEDL dependence, dementia, things like that. Far from perfect. The other idea was to try to train the outside oncologist of doing geriatric screening. Okay. But you're right, the core of the pilot was indeed being able to do that consultation. This was the team I used, and I love international scholars. Okay. Free labor. Free labor. So this is Vérène Dougou. She was the one who wrote the protocol. Niccolò Battisti, who is now at the Royal Marsden. Jae-Jin Lin, who is in South Korea. And this is my right hand, Marina Sehovic, who comes from Montenegro. She's my clinical research coordinator. She's fantastic. And so these people were absolutely key in doing that clinical trial. What we were producing was a case report form that was looking like that. You had a little summary of what the outside oncologist had sent us. You had the list of patients that were matching theirs with their conditions, their age, what they received, what tolerance they had, and prognosis. We were listing which search criteria we had done. And then there was a summary statement summarizing the evidence, providing expert insight, eventually some citations, if we had reference to cite. And that was emailed back to the primary oncologist. And then 2 weeks later, we went sending them another email asking them, okay, was it useful? And did it change what you do? Example, an 87-year-old woman with intrahepatic cholangiocarcinoma, stage 3B4A, ECOG PS1 with hypertension, grade 3, and mild dementia at risk for malnutrition, dependent in IEDL and ADLs. What's the best treatment for that? Are you going to give cisplatin gemcitabine to that patient? So we looked. We found 8 matching patients. The majority had similar geriatric issues. 5 patients were treated with gemcitabine-based doublet chemotherapy. 3 with gemcitabine as a single agent. And gemcitabine alone was well tolerated, but the best documented response was stable disease. There was a better response in a patient with gemcitabine and irinotecan who was enrolled in a clinical trial. And then there was another patient who had radiation therapy and 5-FU who also had a response. So that's an example of, it is a retrospective case series, but it is on demand. It matches the patient. It goes from expert consensus of, what do you think, tumor board guys, are you going to do with that patient? From, okay, 8 patients were treated, that's how they were. Maybe if I do that regimen, that patient will do well. The pilot was 31 patients. It influenced treatment in 38% of patients, modified it in 19% of patients. It was considered useful by most oncologists. And a sure sign was that when I initially presented the study there, they were lukewarm. But they were seeking an association with Moffatt. We were the first study, so they said, okay, let's do it. And then the more time was going, the more they were demanding the consult. And when we finished the study, somebody said, can you wait until a few days before you close? I have a patient. I want the feedback. So that's a good sign. It's really a sign that we are meeting a need from these private practice physicians. The median time of response was 2.2 working days. So we were able to deliver a clinically useful turnover. So now I'm writing the R1. Okay, I'm writing the randomized study. We are trying to create, with some hopefully generous donor, willing to give us $1 million, digital aging and cancer center. And I want to do this translational science using the big data. All right, so what are the low-hanging fruits? As I said, we can use this database to do clinical pathways that are available to clinicians, already can help. We can do electronic consultation for complex cases. We can generate helpful evidence for these underrepresented older patients. We can link that to molecular data. Right now, it's mostly tumor data, but we are collecting blood samples, so we probably could do also some patient-side data. I think it will be progressively automated with language recognition tools, so we are going to be more precise, but the human component at some point will still remain for quite a while. And it's a huge research resource. I think we have to start learning how to exploit that and extract all this data. And that's what I think geriatric oncology is. That's it.